Thank you. Now we are moving ahead to our last talk, and that is diagnostic and management therapies for unusual STEMI presentation. And for this, I would like to request Dr. Kamran Babar, please come and complete the talk very well in 10 minutes' time.
Bismillah ar-Rahman ar-Rahim. Inshallah, I'll do my best. All right, thank you very much. Let me figure this out. All right, so the topic of my today's presentation is myocardial infarction with normal coronaries. So this is a common scenario. I've been working in Pakistan for about 10 years now, and the general trend that we see in the cath lab is about 1/3 of our patients have almost normal coronaries or non-significant disease. 1/3 has PCI-able, straightforward or complex lesions, and 1/3 are actually by guidelines with high syntax score candidates for CABG. The topic that we're going to be covering are the non-obstructive coronary disease, which sometimes can present with ischemia and in sometimes as myocardial infarction. As we all know, while taking care of these patients, we follow the definition of an MI in which either they have to have a positive biomarker, troponin, which actually is one of the most common reasons. Because a lot of patients come with clinical condition, ECG changes, but unless the trop is positive or cardiac biomarkers are positive, we don't take them for cath, especially in the government sector. Non-obstructive coronaries are the ones in which either the lesion or stenosis is less than 30% or between 30 to 50%, but if the troponin is positive, then we are scratching our heads that what is the possible etiology. These are the patients that, when were studied by NYU HARP study, were found to have in about half of the cases these nicely normal-looking coronaries, if you do an additional imaging, would have an ulcerative plaque on IVUS or OCT when you see. So this has become the majority of the real diagnosis behind MINOCA, because many a times you don't see a small dye hang up and you don't see these small crevices unless you do an intravascular imaging for these patients. So remember that whenever we are doing an angiography, we're actually only looking at just the epicardial vessels, which are just 5% of the total coronary tree. The microvasculature is the one that we are not able to see. And many a times this microvascular angina is one of the causes for this patient's presentation that comes in. And these are not benign conditions. Once somebody has a troponin positive, even the WISE study, which was an ischemic study for the ladies in 2017 published in JACC, it was seen that the mortality of these patients in 10 years is about 11%. So these are the patients in which the coronaries are normal, but they have leaked enzymes, troponin. So potential mechanism that we many a time see is most common about in 50% of cases the plaque disruption. But many a times because of anticoagulation that you load these patients with dual antiplatelet, high dose, these clots wash out, and when you do angiography, you don't see them. But we are looking for small 20-30% lesions as thinking this might be the culprit there, and then we are thinking whether we should stent these to cover the unstable plaque or we should leave them for medical therapy. Vasospasm is another one, then dissection, which is another etiology from that point of view. Thromboembolism, normally not very commonly seen. Microvascular showing up as a Takotsubo, and then supply-demand mismatch with extreme anemia or someone who's having really hypoxic or septic with low blood pressure. So it's a working diagnosis. It's not something that you actually just leave on. You have to look at what might be the possible mechanism for these patients' etiology and presentation. The non-coronary causes has myocarditis, Takotsubo, and cardiomyopathy, big one. Pulmonary embolism, renal impairment, and sometimes with stroke and sepsis, these patients can present with abnormal cardiac enzymes and normal coronaries when we do angiography. For the most patients with an MI, if they have renal dysfunction, we know the troponin takes longer time to clear, and that becomes one of the reasons for this patient's presentation. But pulmonary embolism being a clinical disorder can also lead to MINOCA kind of presentation, and you have to do appropriate testing. For most of these cardiomyopathies, myocarditis, and even as an MI, we have to have a backup of having another study, like an MR, which can decipher this dilemma that when the patient's troponin is positive and the presentation is with normal coronaries or non-significant coronaries, then what is the reason behind it? Coronary artery spasm actually requires acetylcholine provocation test, and we're going to talk about it a little bit in more detail. So as this study with this 55-year-old lady who came with anterior wall STEMI was having a normal coronaries on angiography, but actually when you do a CMR on this patient showed the scarred anterior wall myocardium, and that tells us that the clot of this patient actually washed away with anti-dual platelet therapy, heparinization, and when you do an angiography, you were not able to see actually the culprit plaque, which was responsible for this scar of the patient. So CMR is the key investigation that you have to identify for the reason, for the etiology, for your working diagnosis. And that is the message which was even presented in this article by Jack in 2017. European Society of Cardiology actually also emphasizes the similar workup that if somebody is having increased suspicion and troponin is positive and you don't see a significant coronary disease, you should do a vasoactive provocation test. So these are the patients in which you have two options. Number one is that what the mechanism that we don't have in Pakistan is to assess the microvascular bed for microvascular angina. But Abbott has come up with a small pressure wire which actually has a same principle as thermodilutional Fick method that we do for cardiac output. So you place this pressure wire across the blockage, or a normal coronary that you assume is actually the culprit. After that, you give a cold normal saline or any coolant liquid that actually goes in, and with the flow and the cath lab, you can actually see the transit time between the proximal and distal end of this catheter. And that's when you give hyperemic agent, adenosine, to this patient as an infusion, and you repeat the test. With that, you can have an assessment just like an FFR. And this actually modality is using both FFR, IFR, IMR to make a diagnosis of microvascular angina. The other thing that we can't use in Pakistan because of unavailability of provocation agent is acetylcholine, which is actually made by the pharmacist in different doses. And these are the medications that you can only use if the patient is not being given nitrates and is not being given amlodipine. Many a times these patients can't be done an angiography with a radial as well, because many a times you have to give a vasodilatory agent for a radial angiography. So with this, when you give a progressively increasing dose, you can see the coronaries becoming more and more spastic, and that helps you diagnose these patients as vasospasm as one of the main leading reasons for this patient's symptoms. The reason why we want to go in is because the treatment paradigm for vasospastic angina is separate, and you want to bank your money on calcium channel blocker for the treatment of these patients. While for microvascular angina, the beta blocker are the medicine of choice, and calcium channel blockers don't give much relief. So these are the reasons you want to really have a diagnosis in terms of your cath lab as well as CMR to see whether it's a missed plaque, it's a cardiomyopathy, myocarditis, Takotsubo, and many a times you are not able to see, even in 1/4 of the time, the cases which are responsible for your diagnosis. Now, coming to the long-term treatment, statin and renal RAS inhibition are actually more promising, but you don't get much benefit from beta blockers or antiplatelet in these patients with MINOCA. Lastly, coming to the spontaneous coronary artery dissection, by classification, we know that these are smooth narrowings that we see. The history is normally suggestive, sometimes with pregnancy associated, hormonal associated. You see these SCAD patients who come in the middle of night with STEMI presentation on ECG. So you have to treat these patients conservatively if you can. I mean, doing angiography, PCI, many a times does not solve the problem. And many a times you have to do an imaging because you want to know the etiology of these diagnoses. Inside out and outside in theory means that for microvascular rupture, these vasa vasorum are the one responsible for the plaque, and then you form a false lumen which is pressurized. And if it is non-fenestrated, then it will make the true lumen smaller and smaller. While if the plaque ruptures and then the contrast exacerbation goes into the outside, so that becomes the responsible mechanism by which these patients are having a coronary artery dissection and acute MI, because that is going to be compressing the true lumen. When you do further imaging by OCT or IVUS, they both have their pluses and minuses. IVUS cannot help you differentiate atherosclerosis versus false and true lumen interface because of low spatial resolution. While in OCT, you have to give high pressure contrast to flush with saline, and many a time these are difficult to, and that might worsen your dissection in these cases. The management, don't give thrombolysis. If a pregnant patient is here, treat them as a normal person. Don't hold on their right of having primary PCI for these patients. But if you can manage conservatively, the 3-day rule is the most important one. But if it's an unstable patient with ongoing ischemia, many a times if you use a cutting balloon to make a fenestration, that helps to let the false lumen decompress, and then the true lumen will heal, and you can bring this patient in about a month's time for better management in PCI if needed. Thank you very much. I will end here. Do not give anticoagulation in 2B3As for these SCAD patients. Dual antiplatelet, beta blocker. If it is pregnant patient, then don't give statin, and post-delivery you can give statin to these patients. Thank you very much for your attention.
Thank you, Dr. Kamran. It's a wonderful talk, and we really appreciate all the speakers who have tried to finish very well in time. I would like to take a quick comment from Dr. Khalda Sumro. She is on Zoom. Ma'am, are you around? A quick comment.
Yes, I'm here online, Ambar Malik. I want to give my comment on the last case. He rightly said that unusual presentations of STEMI, such as MINOCA, spontaneous coronary artery disease patients require specialized diagnostic and management strategies, as well as MINOCA patient needs initial evaluation, which should be focused on identifying the non-coronary causes of myocardial injuries, such as myocarditis and pulmonary embolism and other reasons mentioned by him. For spontaneous coronary artery disease patients, prompt recognition and diagnosis are very much crucial. Diagnostic strategies include invasive and non-invasive tests like CMR. The role of CMR over here is very much important. Management strategies include optimizing the medical therapy, identifying and treating the risk factors, and referral to specialized centers for further evaluation and management consideration for the revascularization in selected cases. But I want to emphasize that we should focus on our population, our GPs, which despite of seeing the prescription by the cardiologist after the coronary angiography, especially in MINOCA cases, if they see minor irregularities or if there is normal coronary artery, they stop the medication, despite of the fact that patient is having MINOCA. So we have to create education regarding our awareness regarding this problem in women, especially in masses of Pakistan. Thank you so much.
Thank you, ma'am. It's really nice. And for the final comment, I would like to request Professor Dr. Naeem Aslam.
Thank you very much. This was a really excellent session, and everyone enjoyed the excellent talks and very informative. And especially would like to thank the organizers, especially Professor Barakram, for their excellent hospitality and excellent arrangements. We are already late, and I would like to thank all the audience and speakers for sparing the times and having prepared so nicely. Thank you very much.
Thank you, all the chairs, all the speakers. Now I am going to hand it over to for sixth session to Dr. Professor Hashmi Kashif. Hashmi Saab, please come upon the stage and moving ahead to another important session, that is structural and peripheral heart disease. Thank you very much to all of you. Thanks a lot.